it going?
Good. Well, good. Welcome to Heart to Heart, episode 3.
3.
Yeah. So February is Heart Month, and I thought that, we thought that it might be a good chance to talk a little bit about hearts, specifically women and heart disease.
Yes.
There is a big push with the Canadian Women's Heart Health Alliance and Her Heart Matters and the Wear Red campaign. And so we're going to spend a little bit of time talking about our own personal experiences with women and heart disease over the years. So
yeah, I think it's a great topic, and I think a very well deserved topic. We know in terms of research alone that predominantly the research that is kind of guiding the way in terms of heart health and how we manage and treat heart health, majority of the participants in the research are men. So I think it's a good thing to kind of keep bringing awareness to women specifically in terms of heart health and
heart disease does present differently potentially with women. Women tend to have different symptoms. We used to call them atypical symptoms, but they're not atypical. They're just the symptoms that are more commonly associated with women, specifically with heart attack, and we'll talk a little bit more about that. But they also have different types of heart conditions that are more predominant in women. We're going to touch on that a little bit as well.
So we thought we'd start with a little bit of our own background in terms of experiences that we've had specifically with women and heart disease.
Yeah.
Do you want to start?
I do.
Okay.
I actually have a story that has stuck with me for now 20 years plus. And it was a story when I was an emergency room nurse in Manitoba. And it was very... it stuck with me to the point that I now am a huge advocate for women and heart disease. It was a night shift. I was sitting at triage. Actually, it was probably late evening because it was just before my shift change. So probably about 6:30 or 7 o'clock at night. And a lady presented with her husband beside her. And she was in her late 70s. And she came in, and as we do at triage, say, what brings you to emergency tonight? And she told me that she had abdominal pain. Her belly was hurting. And so with triage, we do the vital signs, and we try and get a bit more of a story. And this is pain that had been coming and going all day. And currently she wasn't having any pain, but she thought she should get checked out. And so I did her vital signs, and they were stable. And I actually even remember telling her, I said that sometimes women, yourself, make us work pretty hard at triage to try and figure out what's going on, because abdominal pain can be a number of things. I, in my head, was thinking it could potentially be her heart. So we used a triage acuity scale. Our emergency department was busy as per usual. And because she wasn't having any pain and her vital signs were stable and there was no room at the inn, I asked her to go to the waiting room. I specifically told her that if she does get pain, to come back to the triage nurse. And that was sort of the end of my shift. At that point, unfortunately, we didn't do cardiograms, the ECGs, in the waiting room in the hospital I worked at. It would have been a very handy thing because when I came back to work the next day, I talked to the nurse that took over for me that night. We do 12-hour shifts, so they told me that that lady came back to them and told them that they were having pain. They brought them in actually quite quickly, and when they did her ECG, she was having what we call a STEMI. So it was a heart attack that you can see on an ECG. The treatment for a STEMI is give them a clot-busting medication at that time to break up a clot, and then go from there. And we, I guess, gave the clot-busting medication. It didn't work on her. She ended up going quickly to the hospital in the city that does angiograms and angioplasties to try and open up the blockage. And I found out that the next morning that she had died. So it's definitely something that stuck with me. I honestly don't know that sitting in the waiting room for that bit of time without pain would have made a difference had we got her in earlier, or whether we could have done the ECG earlier and it would have made a big difference. It's really hard to know, but it's something that's stuck with me.
Absolutely.
And it's I have never forgotten, and I never will. And so that was a tough one for me.
Well, thanks for sharing that
Yeah.
story. That's a hard story.
It is a hard
especially as a younger nurse to have something like that happen, and you feel,
Yeah.
obviously partly like you're taking on a little bit of the responsibility there, which isn't necessarily, but something that you.
Well, yeah.
Yeah, it's hard.
It is hard. I think I did kind of trigger that it could be her heart, and that's why I told her to come back. So I felt good about that. As a triage nurse, when you go through training, they talk about the fact that you will put people in the waiting room who are having a heart attack, and you always be like, "Oh, I'm not going to.
Not going to be me."
Well, I did,
Yeah,
and
yeah.
unfortunately, she didn't make it. So, yeah.
So how did that change? How did that change you moving forward?
Well, it definitely made me consider that women have different symptoms with heart disease, and I had, you learn that. But at that point, over 20 years ago, it was not as mainstream as it is now. There's much more awareness that women can have different symptoms. It was on my radar, and so I definitely, and especially now, I've worked in cardiology specifically in the cath lab and the electrophysiology lab now for 14 years. My last 14 years. So I see a lot more heart-specific stuff and not so much of the other things that you might see in emergency. I am a big advocate as well in our department. It's so often that we say, "Are you having chest pain? Are you having chest pain? Are you having chest pain?" And it doesn't apply to everybody. Not everybody has chest pain. And some people say, "No, I'm not having pain. I'm having pressure." Well, I think it's important to say, are you having chest discomfort, or are you having symptoms of discomfort? Are you not feeling your same? And I teach that to the nurses that I work with, and I tell patients, because I tell them, I say, you may hear someone ask, "Are you having chest pain?" And if you're having heart symptoms, at this point they may have been in hospital for a number of days and presented with arm pain or jaw pain or abdominal pain. And I tell them, if another nurse says, "Are you having chest pain?" and they're not having pain in their chest, but they're having symptoms that made them come to the emergency, that they should say, "No, I'm not having chest pain, but I'm having these symptoms that I had when I came to the heart."
Right. Why don't you share, you were telling me before about some different types of symptoms that you've heard that you're like, okay, now.
Yeah. You do hear different symptoms, presenting symptoms, and actually both of these stories were with men, but it definitely could apply to women. And I had one gentleman, and this was back in Winnipeg quite a while ago. He told me that he had pain in the top of his head.
Wild. Like, I'm trying to think physiology, like how that would even, what the radiating thing would happen that you'd have pain at the top of your head.
I don't know, but at that point, you're not even, my next question was, did somebody hit you in the head, or did you fall, or are you having headache? You think about brain stuff. And it was his second heart attack, and he said, "This is the exact same thing that happened to me, and nobody thought it was my heart, and I had a heart attack." And it's this exact same thing. And sure enough, we brought him in, and he was having a heart attack. I also had a very similar story with someone who was having pain just in their hand. Yeah. It was a male, just in their hand, and it was his second heart attack, and he told me, "This is the exact same pain that I had when I had my heart attack previously." And so we brought him in, and he was having a heart attack. So when you present to the triage desk, whether you're a woman or a man, if you have a cardiac history and you know what your symptoms are, you tell them what your symptoms are and say, "These are the same symptoms I had when I had my stroke or when I had my heart attack." Yeah. And the other thing is that don't limit it to just one thing. Triage nurses will say, what is bringing you to the emergency department, and if it's abdominal pain, but you're also feeling sweaty or dizzy, you tell them all of the associated symptoms, and you tell them that, I'm concerned that this is not how I normally feel. You know your body best, and maybe I'm having something going on with my heart. Or I've heard of somebody having these symptoms and they had a heart attack. So advocate for yourself. Be really specific. Say, if you're having chest pain, say I'm having chest pain, or pressure in my chest. Say exactly what you're having, but all the other symptoms that you may be having as well.
Yeah, it paints a bigger picture.
It does.
Right?
And when you know your body best and you explain that I think there's something going on here, it helps the triage nurse get to the bottom of what's going on.
Yeah.
And if it's not your heart, fantastic.
Yeah.
Nobody will be upset if you're in the emergency department and you're not having a heart attack or not having a major problem. It's okay. It would be the opposite if you decided not to come in because you were concerned that you were going to take away time or something.
And that's something too, you know, at the university currently, working with my students, and one of the courses that I'm teaching last term was clinical assessment. And it's one of the things that we're teaching the students in terms of just trying to gather the information, because you get a bigger picture and you're able to put the puzzle together a little bit better. And that when you're dealing with someone who has had a cardiac event in the past, that it's really important for us to understand what were those symptoms. Because chances are, if we feel those or sound like those symptoms are coming on again, then we can kind of connect back to, oh, this could potentially be their heart again. Because, you know, whether it was low back pain or belly pain or jaw pain or whatever, or just feeling
tightness
off
or whatever it was,
really fatigued or whatever it might have been, it's something that those same symptoms, if you're going to have a reoccurrence, you'll feel it in the same way. So it's good for us to understand what that is.
Hearts send very consistent messages. It can be slightly different, but often they do send very consistent messages.
So it's good for us to understand.
So that was a big one. And so just as an aside, if you're having triggers with us talking about these scenarios or these stories, please reach out for help and use your supports. Our intention is to raise awareness and help. But obviously some things may ring true to you and may make you have different feelings.
For sure, for sure.
Yeah, and then so that was a heart attack situation, right? And so heart attacks are when, you know, part of your heart muscles not getting oxygen and all that stuff. But there are other things that can cause symptoms that may mimic a heart attack. And I wanted to talk about something called Takotsubo, cardiomyopathy. Or you want to talk first?
No, it's fine. You go first.
No, you talk.
Well, I was going to share one of my stories, if that's okay.
No, I think that's probably a very good idea. Yes.
Okay. Well, oftentimes for me, and I don't necessarily have a specific story like you, but I do obviously work with a lot of women who've had cardiac events. And one of the key messages that I continually hear from a lot of women, not all, but from a lot of women, is just this feeling of not being heard, that they're just not heard. That potentially it could be right from emergency, presentation type thing, where it's just they don't feel like they're being taken seriously or heard when they present. That it's, oh, you're having a panic attack, or it's anxiety, or oh, you must be stressed out at home, or there's sometimes other things that I think for these women in particular, they're like, no, there's actually something wrong, and I want you to hear me that there's something wrong here. And so they'll get sent home and come back, and sent home and come back, which is sad and challenging for women, because obviously you're going for help and you sense that something's wrong, and you're going for help and you're relying on the professionals there to assist you. And so when they tell you that no, there's nothing, or it's anxiety, or that it's this, sometimes it's hard not to believe that, right? To be like, oh, well, maybe it is. Maybe I am having a panic attack, or maybe I am stressed out. But then everything in your body is saying, no, there's something actually wrong.
Right.
And so it's this very kind of hard sort of mental place to be. And sometimes too, it's not necessarily right in the sort of emergency presentation thing. It's something where, they might get in right away and get care and whatever, but it's, and this can be for everyone, but I do find this with women as well, that it's the aftercare of kind of being left with now what, right? And
the follow-up
stuff of like, okay, well, I got in and I found out that this was going on with me, but now I'm kind of like sent home and I don't really know what to do. Sometimes it's even challenging to get a follow-up in what you think you should have. And this is where, as Cam was just about to talk about, women are sometimes at more risk, more prevalent risk of having certain types of heart conditions. And so a Takotsubo is a type of heart attack that doesn't impact, it's not the plumbing necessarily, the coronary arteries necessarily, that's the clogging sort of issue. It's the muscle of the heart itself, right?
Right. Yeah. We'll talk about it.
Yeah, and so we'll talk a little bit about that. And so these types of heart attacks, which are kind of sometimes coined broken heart syndrome type heart attacks, where they often will follow some sort of higher stress event, but they don't necessarily need to, but oftentimes they follow some sort of higher stress event, kind of a hormonal or emotional surge, that type of thing. There's SCADs, which is another type of heart attack, microvascular disease, which is another type of heart issue as well, that do tend to happen more often with women, and sometimes even younger in the pregnancy sort of time as well, where you're dealing with a whole bunch of things. And it's not, with these types of conditions, there's not necessarily the kind of process in place in terms of the care following that, where if you have a heart attack, for example, and it's a clogged artery, well, okay, we'll fix that artery, and here's the artery, and here's the medications you're going to go on, and here's your follow-ups, and here, you're kind of in this route, in this path, where some of these other ones don't have that same sort of pathway. And so sometimes women feel like, okay, I got this diagnosis that I had this Takotsubo, but now what? Like, I don't even necessarily have a follow-up with a cardiologist afterwards, which is challenging, or a SCAD or microvascular disease, where you're still left sort of searching to figure out, well, how do I deal with things moving forward, which can be challenging.
Sure, and it's not just through emergency.
No,
sometimes it's through a family doctor.
Yes.
It can be, I just haven't been feeling myself, or whatever.
Yeah.
So, yeah. And I think this probably isn't the venue to teach you all the ins and outs about all these conditions. I think there's...
How long do you have?
Yeah, there's a lot of information that we can go through about all these specific conditions, and maybe we will in other heart-to-hearts. But I think the important thing to know is that there are these different conditions. And so I will talk about a couple of them, just because we see them regularly in the cath lab, and sort of how they present and what they might mean for you, and sort of where you go down the road. But I'm not going to get into all of them. So the one I was going to mention was this thing called Takotsubo cardiomyopathy. And so Takotsubo is actually a Japanese word for an octopus trap. And so it's the shape of an octopus trap. And the thing that's the shape of an octopus trap is actually your heart muscle. And as you mentioned, it's very common after a surge of adrenaline type medications in our body. So after a stressful event, so it may be the death of a loved one, or
a fire, or
a car accident, or something traumatic. That's the most common cause. And so your body sends out this surge of adrenaline type hormones into your blood, and it actually stuns the heart muscle. So it has nothing to do with blocked arteries, and it doesn't cause specific heart damage in a certain area. But what it does is it weakens the heart muscle, and gives you the same symptoms of a heart attack for a lot of people. And so they call it a doppelganger. It actually, people often get chest tightness and heaviness and pressure, and may feel not well, and may be sweaty, and all these symptoms that could be a heart attack. So in emergency, and in addition, they may have changes on their ECG that suggests they're having that STEMI. So we rush them off to the cath lab. We take our pictures, we get in there and do our angiogram, and there's no blocked arteries, but we actually go in and we take one picture where we fill the left ventricle, the pumping chamber of the big pumping chamber to the body of the heart, with the contrast, and we watch how it pumps in it, and then it doesn't squeeze properly, and it looks like this octopus trap. And so we have a diagnosis of this Takotsubo cardiomyopathy, or broken heart syndrome, it's also called. And so it is far more common in women, and the treatment is medications. Most people completely recover from it, I know it's
just
unnerving.
As scary.
It's very unnerving.
It's
absolutely.
just as scary, and for some, it's kind of like, well, how do I make it so it doesn't happen again? Or it wasn't necessarily that it happened after a big event that they can tie it to, or something, which is challenging. Which is challenging.
And it is interesting. We see people right in it. They just come to the emergency. They have these symptoms. They come to the cath lab. We take their pictures, and then we say, you're not having an actual heart attack. And so, most of the time it's relief. Sometimes it's I wish I did, you know, like
and
you were
then
saying.
actually it's a thing.
Yeah.
Then it's like, okay, well then
Yeah.
I know, and I can like make my
Right.
plan and fix it. Yeah.
And you know, if it's a first time or a one time thing and people recover and never happens again, great. But sometimes people have repeats. And so that's, again, it's kind of unnerving for these people. So that's one of these things that we see sometimes. And another one that we see in the cath lab is this thing called SCAD. And you mentioned that too. And that's a spontaneous coronary artery dissection. So it's not the typical, you have plaque buildup and then it ruptures and you make a clot and it blocks blood flow and you go from there. It can block blood flow. It's when the inside of the artery wall tears and a flap can form and it can block blood flow completely or temporarily. And so ultimately people often end up with an angiogram because their heart is under some stress and may have some markers on enzymes and blood work that might suggest there's some heart damage, so they end up with us. And most commonly we treat it just with medications unless there's something that we are positive we can make better with a stent, but people tend to do better without them if they have blood flow down that artery. But it is another one that can sometimes present itself again, and we do treat with medications and sometimes a stent, but it doesn't mean you're not going to have another one, and that's a tough one. We see repeat customers, not customers, repeat patients come in with the same problem, and it could be in the same artery or a different artery, and it's very hard for them because what do I do? What do I not do? And so it is,
Yeah, I think that's where honestly our biggest job is when we're working with patients who have these events and these issues, is helping them to figure out what they can and can't do, right? Because there's this sort of feeling of paralysis in a lot of cases, and if that's you, you're not alone, because it is something where obviously you don't want anything to happen again. You're trying to figure out, you know, how do I make this better and how do I continue to move on with my life and get healthier and get stronger, but in a way that doesn't predispose me to maybe have this happen again. That's not irritating and causing all this inflammation and stress. And so, I think there's a huge mental piece to it all. There's really a big mental piece to all of it. Yeah,
absolutely. And it is, I know I see people earlier and you see people later. And so there's different responses at different times as people work through situations in their own head. We do know that living a healthy, active life is good for you, but there may be some things that you have to avoid for a bit or avoid, you know, whatever. But yeah, it's a tough one. And we do know that doing nothing generally is not the best thing for anybody.
Absolutely.
But it's hard not to feel that way, I think, at some stages, especially if it's happened more than once.
Yeah.
So, yeah.
Well, let's talk a little bit about, you know, you mentioned the presenting to emergency. And, you know, one of the things that I was mentioning as well is sometimes women feel like they're just not heard, right? And so do you have any, as a person who's worked in Emerge for a lot of years, do you have any sort of tips or ideas of how to help yourself be heard?
Absolutely. And I think this could be also with your family doctor, but definitely at the emergency triage. And I actually just watched the Canadian Women's Heart Health Alliance webinar, national webinar, and it was on chest pain in women. And they had similar suggestions, the same suggestions that I'm going to say right now, is that if you're having chest pain or discomfort or something in your chest, it's still the most common symptom for women, even though some people may not have chest discomfort, is to say that you're having that. And not only that, but say if you're having any other symptoms.
Yeah.
And I've mentioned this, but I'm also feeling quite nauseous, or I'm feeling quite weak, or I'm not
because
sleeping
as
or
the
anxious.
symptoms add up, you're kind of like, oh, okay, right?
And it's not bad to mention that I am concerned that this may be my heart. If you have heard our talk or someone else have similar symptoms and it turned out to be a heart attack, say I'm having these symptoms and I'm concerned that I'm having a heart attack, or I'm concerned that this is my heart. So I think that's very important. The other thing to say is what I talked about with this, like the guy who had the pain in the top of his head and his hand, is I've had similar symptoms and it was my heart. And make sure you tell them that, because that is a red flag, absolutely. And the triage nurse will go from there. There are processes in place, and we all know that emergency rooms take on all comers, and there's all kinds of people, and it's the triage nurse's job to figure out what's more serious and what's not as serious, and try and get the appropriate things rolling for the patient that they can. And so anything you can do to help their job is good. You need to advocate for yourself. You need to be specific about your symptoms and what your concerns are.
And I think too, a lot of us maybe haven't been to emergency. Maybe some people haven't been to emergency, or you have this idea of emergency is only if I'm like emergency, like
Right.
I can't breathe. I can't breathe. My arm is chopped off, like something that's like major. And so it's almost like some people talk about kind of almost going through this like how bad is it scale in their brain before they'll actually take the step to go of like, oh, we're not there yet. We're not there yet. We're not there yet. Like this might pass, or I don't want to be there if it's not actually an emergency, or I don't want to, it might be not something that they want me there, or, kind of just go. Like the idea is.
Yeah, and time is very important.
Yeah, just go. It's something where, the nurses and everybody are there regardless. And so you showing up and having it be something that isn't necessarily something that is an emergency at that moment, it's better to go and be told, you know what, I don't think so, and be sent home than it is to not go at all.
Right.
And then the other piece of it is I think we have to be real strong advocates for ourselves, and not that anybody in the healthcare system is actively trying to block you from getting care, but I think sometimes things can be presented in different ways. And if you have gone to hospital and they have said, you know what, I think you're okay, I think you can go home, but there's just something in you that's just saying, no, this isn't right, go back. Like just
if your symptoms come back, go back.
Just keep going back.
Absolutely.
Yeah. Keep advocating for yourself in that way, I think is really important.
Yep. And you will hear physicians and nurses telling patients, we couldn't find anything, but if these symptoms return, please come back. Absolutely. And so if you don't hear that, that doesn't mean that it's not true for your situation, but if your symptoms return, go back.
And I think the same sort of thing applies to the afterwards as well. Like, we're talking about, the early on going to emergency, but also in terms of your aftercare, and being an advocate for yourself in that way as well, in terms of talking to your family doctor, reaching out for support wherever you can, so that we can help give you that process or help give you that path.
Search out cardiac rehab. There's virtual options for cardiac rehab if you're not referred, and absolutely.
Get that support so that you can be sort of guided and assisted, as you're trying to navigate afterwards. I think that's such a really big thing.
Women and heart disease is definitely awareness is improving, and this is a fantastic thing. There is work to do still, and hopefully this helps, but we need to continually study and learn and grow and make our healthcare system better, and teach patients what they need to know, so that they can take care of themselves better. And hopefully this is one step. So I think it was a good talk. There's lots to it. This obviously isn't everything. This is just this is a start. So we'll probably talk about similar things down the road as well in some of our heart-to-hearts.
Well, thanks, Cam.
Yeah, thank you. Thanks for listening.
All right. Take care, guys.
Yeah. Bye.
Bye.